So we have a little addendum for you. We are speaking about tumors and screening and treating all the time, but there is more to colonoscopy, since in the IBD field, things have changed. Because in the past, I think we have been looking to see more or less severe disease and were busy with grading the severity of disease. Now the whole complex of mucosal healing comes into play, so we have to look at hopefully normal or nearly normal mucosa. And I think to give some background what's going on, there was a recent study, an inquiry of gastroenterologists dealing with IBD, what they were busy with, and I was very surprised to see that so many use gradings and classifications and scores, the conventional ones. But also when asked, they seem to suffer a little bit, because when people were asking, do you think AI really fills a gap or meets a need, then 70% said yes, and not only in endoscopy, but also in histology, because that's another story, the inter-observer variability, etc., etc. And there were, the significant studies are a few years old, actually, that AI was used to differentiate between ulcerative colitis and Crohn's disease, or grading the severity. And as usual, you know, these studies start on images, on videos, and they try to reach a discriminative level. And I think we have to wait, but there is a huge need to help us with the grading and classification, number one. But maybe it's not only endoscopy, so AI could, and that's a tendency coming up, not only using one imaging modality, but also clinical data and lab values, etc. So speaking briefly about the current practice, Manmeet, you certainly in your colon clinic, you have a large collective. There was this ancient discussion about not doing biopsies because endoscopists' eyes see everything. Is that really true, or what's the practice and the tendency?
So I think there is a cultural shift towards biopsies and how we view those. But I think, you know, we shouldn't kid ourselves. Endoscopists' eyes don't see everything. However good you are, we will miss dysplasia. And, you know, having spent a lot of time doing this, you know, we all know it's still quite difficult to pick up those dysplastic lesions at a stage where we can deal with them. So I think going right back to basics, you know, thinking about your patient cohort, these are patients that have to come for regular surveillance, so making that high quality procedure from the beginning so you get good bowel prep and you get that adherence. Using all of your adjuncts, as we've talked about, with regards to sort of your imaging techniques, but also really thinking about, you know, the medical advances in IBD such that we do now have that ability to get that mucosal healing such that the inflammation is not present and we can actually really look for that dysplasia. And when you couple that with high zoom, high def scopes, near focus, you can really interrogate. And, you know, the thinking is that actually we should spend more time washing, looking, turning the patient, making sure we optimize the views and really targeting our biopsies to what we think might be specifically dysplasia. And thinking about actually, you know, historically we have this ideal that if you have dysplasia and it's not resectable, then, you know, that's it, a pan-proctocolectomy. But increasingly, I think there is a shift towards actually thinking about endoscopic resection. It does have a place. Some patients find it really difficult to take, you know, the concept of dysplasia not being cancer and, you know, the risks of surgery are not acceptable. So then you have this idea of, you know, having a second screening, having a second opinion, really hunting for that. But also, I think, you know, thinking about, you know, sometimes segmental resection, you know, is now a discussion, although it's not what we're traditionally used to. So I think thinking about chromoendoscopy, thinking about NBI, thinking about using, you know, your high-def scope and really mapping the whole of that colon, because it's very easy for your eye to be drawn to the obvious thing, but actually you might then miss the subtle flat dysplasia that actually you really need to look for. This skill takes time, it takes training, we know it's very difficult, and, you know, we're not perfect at it. So it's a perfect storm in a way. And as I said before, sometimes, you know, the patients need to hear the word cancer and not dysplasia before they're willing to make a difference with what they might do treatment-wise. So it is an interesting discussion endoscopically as well as surgically.
So again, we probably have been doing too much, and the tendency, you say, is doing fewer biopsies with a higher yield because we see more, and at the same time not sending everybody to surgery if one dysplasia appears, but maybe watching, endoscopically resecting. So that's very interesting. But Michael, if you listen to these things, artificial intelligence, there are huge expectations. There are some methodological requirements before we can use that in this very difficult setting, because it's more difficult than polyp normal mucosa, isn't it?
It is very difficult. It's much more difficult. In this program, you are the technology optimist, Thomas, and I am probably more of a pessimist, or as the pessimist would say, I'm a realist as opposed to you. So I think it is much more difficult. I'm not quite sure how far we will get with AI in this context that Manmeet so nicely described. I think we can do a lot also without AI, with new endoscopic features, with better imaging of the colon. We have been speaking in previous episodes about enhancement, for example, with different methodologies. I think with IBD and endoscopy, there's these two very interesting areas. The one is Manmeet described so nicely, which is the recognition, the diagnosis of dysplasia. So progress associated with neoplasia development. The other thing is about the inflammation, because in IBD we believe that inflammation triggers development of neoplasia, but it's also, and endoscopy I think here will be much more interesting in the future, is about the prediction to treatment and the prediction to recurrence. So we're having this big discussion now, not within endoscopy, but within gastroenterology and rheumatology, if and when to stop, for example, with biological treatment. Should patients stay on forever? Should it be stopped? How should it be stopped? When and in whom should it be stopped? And there, I think endoscopy could be very, very interesting in the future to predict. With endoscopic images, with AI, without AI, I don't know, with endoscopic images to predict the risk of recurrence, for example, if you stop treatment with a TNF-alpha inhibitor. And if we could predict
or one of the newer drugs.
Or one of the newer drugs. If we could predict that with endoscopy images, and I think we're moving in towards that direction, that would be very, very interesting. We could stop treatment in the people who don't need the treatment, continue treatment based on endoscopic images in the people who still need it. I think that's very interesting. There are studies going on in that area, and I think that's where we will see a lot of interesting findings in the next years.
Well, I'm a skeptical believer in AI, and the skepsis comes from the fact that I think most studies are done very lazily, and they want to have results with very basic material. And what you describe is extremely complex and needs a precise, meticulous documentation in large numbers.
And the follow-up.
And the follow-up, right.
You need to know, what's happening to these patients, and the counterfactual. What would have happened if you have done things differently? Extremely difficult studies to do.
Yeah, many factors who influence the outcome, or which influence the outcome, and so you need a large database, basically. So it appears possible, but with much, much, much more work.
I agree.
And I think the flavour of the patients within the IBD world is also changing. So if you think about, the sort of, brilliant sort of multidisciplinary joined up care and the improved outcomes, early surgery, top-down therapy, we're actually surveying these patients for potentially longer. We've got better immunomodulator and, biologic drugs to treat them with, but we obviously then got an older age group potentially, and therefore we have to think about sporadic adenomas that might not be necessarily related to dysplasia in the IBD sense, but actually we have to think about dismissing those potentially if they're not in an area of inflamed colon. But also, training your eye to look for those areas of regeneration within post-inflammatory polyps where we know that we can get sort of higher risk lesions that are missed. And also the serrated lesions that we do see in IBD that I know that we're studying to see, because we don't know the significance of this, but there may be an accelerated pathway that sort of skips the classic sort of adenoma-carcinoma sequence, and we might have serrated lesions that, have a completely different biology. So And then when you take that, I think, in the context of the patient and their changing biology, and you think about the drugs and the IBD in the background, inflammation, it is quite a complicated sort of jigsaw to put together. And I think it is an evolving field.
But you could say complexity requires some form of artificial intelligence to structure it. So we will see. So we'll keep you informed about this very exciting topic. Thank you for listening.